Okay, so because the cardiac or respiratory motion, the tumor can move, and that's what causes the uncertainty of the tumor position. And this can lead to undesired results like damaging of normal tissue. So we need to monitor the tumors in real time. However, the real-time imaging is challenging for two main reasons. The first reason is the time limitation of real-time imaging. The MPN test group 264 defined for a real-time process for MLC tracking if the latency is less than 500 milliseconds. And Campbell Washburn et al. Suggests for real-time MRI cardiac intervention, the latency should be less than 200 milliseconds. The latency here is defined as the time between the target motion and the complete execution of the system response, which include the contribution from the position monitoring, the computation of the prediction algorithm and MLC tracking, and also include the execution of the MLC instructions. So we have to complete all these tasks in under such a short amount of time. The second reason is due to the low contrast of liver tumors against the surrounding normal tissue in the onboard X-ray projection. Here I show you an example of the onboard X-ray projection. So even if you have X-ray eyes, you probably still very difficult to locate where the tumor is. Moreover, because the time limitation, only one or few onboard projection can be acquired, and this significantly reduces the amount of information can be used to locate liver tumor. In our previous study in this group, we have tried to track the liver onboard liver tumor position, combining 2D, 3D deformable registration and vital modeling. These slides illustrate the basic idea of 2D, 3D deformable registration. Even though the tumor is hard to see from the onboard X-ray projection, the liver tumor boundary, especially the diaphragm, can be clearly seen from the projection imaging. And we can use this to help us to locate the liver tumor. The idea of basic the 2D, 3D deformable registration is to find the deformable vector view that would deform some prior imaging, such that the simulated X-ray projection from a deformed imaging will match with the onboard projection. And this intensity-based algorithm has good performance, especially at a high contrast regions such as the diaphragm. Therefore, the deformation factor view at the boundary region can have a high accuracy. Then we can use this combined with the biological modeling to obtain the accurate tumor position. The basic idea of biological modeling is we model the liver by some biological model. Then we use the liver surface boundary deformation estimate in the first step to 2D, 3D deformable registration as the boundary condition. Then we solve this boundary failure problem to obtain the intra-liver deformation and use that to track the liver tumor. So, however, this combination of 2D, 3D registration and biological modeling cannot be used for the real-time tracking. One of the reasons is the 2D, 3D registration is an iterative algorithm, which is time consuming. Moreover, in last situation, we can only use 20, we have to use like 20 projection onboard projections, which can not meet the requirement of real-time imaging, which we can only have one of two. Therefore, we propose a deformable registration approach, which will replace the first step, the 2D, 3D by a graph-based neural network to estimate the liver tumor deformation. Then we combine with the biological modeling to help us to track liver tumor. And this two-step scheme will simplify the complexity of the deep learning model, and the biological modeling will introduce the domain knowledge, which can complement intensity-based information from the X-ray projection, and this will improve the registration and localization accuracy. Our method is motivated by the Pixel-to-Mesh paper published in 2018. In that paper, the authors can reconstruct a 3D shape from a single camera view picture. However, our methods are different from layers because our method is more like a registration than a reconstruction approach. So our approach is more complex, is less complicated and more robust. Moreover, because the X-ray projection provides more information with X-ray radiation will pass through the patient, so it will provide the depth information. So we are hypothesized a lot from X-ray projection, we are able to reconstruct the 3D shape of the liver surface. So here I show you the workflow of the proposed method. As just mentioned, in the first step, a deep learning network was trained to predict a liver surface boundary deformation vector view that will deform the liver surface, acquire liver surface mesh, such that the deformed imaging will match with the onboard X-ray projection that encode the motion variations. Then in the second, the price liver surface mesh can be generated offline, which takes no onboard time. In the second step, the intra-liver DVF will be solved using the liver surface boundary condition as in the first step. In the following talk, I will focus on the first step, which is the major contribution of this work. These slides give an overview of the graph neural network architecture. It looks like a busy slide. However, the network can be divided into two subnetworks. The first subnetwork is the feature extraction network that will extract features from an onboard X-ray projection. This subnetwork contains a backbone network for feature extraction, and extract feature will be pulled by the perceptual pooling layer. Here we use the resonate 50 as the backbone. The second subnetwork consisting 3 deformation modules progressively deform the prior liver surface to match with the onboard projection. Each deformation module contains a graph convolutional network that predicts the liver surface DVF and the special transform layer that will deform the liver surface mesh based on the predicted DVF. In order to train this network, we use the similarity and regularization losses to drive the learning process. Here I show you the relations between the perceptual feature pooling layer and the graph neural network. This figure, upper left figure shows is the perceptual feature pooling layer. So the perceptual pooling is based on the position of the liver surface node. Then after the feature pooling, they pull the feature will fit to the convolutional graph convolutional network to predict the liver surface DVF. In the following, I will give more detail of the perceptual pooling and the convolution network. These slides illustrate the basic idea of perceptual feature pooling layer. That will associate each 3D nodes of the liver surface with the 2D points in this feature map. So here we use the same combing geometry of the X-ray imaging. We have the X-ray source and liver surface mesh in the onboard position. However, the X-ray projection is replaced by the feature map extracted by the resonate 50. Then for each, then the 3D nodes of the liver surface are projected on this feature map, and the corresponding features associated with each node of liver surface are pooled based on the projected 2D points. Then this pooled feature will fit to the graph convolutional network for the PDF prediction. Here I show you the detail of the graph convolutional network for this, because we model the liver by a liver surface mesh, which lack the Euclidean data structure. We have to use graph-based convolutional network to perform the convolution operations. The graph convolution network consists of a series of graph convolution layers that are organized in the residual learning structure. The input is pull the features and also learn the features from the preceding deformation modules. Then the network will predict a liver surface DVF for the deformation, and also learn the feature, vortex feature can fit to the consecutive deformation modules. In order to test our idea, we use a data set of 10 patients with liver cancer. each patient has a 10-phase CT. Because there's no onboard combing projection associated with the data set, we have to simulate these X-ray projections from the 40 CTs using the ray tracing algorithm. Since each patient has only 10-phase CTs, there's not enough data to train the deep learning network. We have to augment the data set. Here we have to augment data set to generate realistic respiratory deformation encountered in the onboard situation to onboard X-ray imaging situation. Here we use the principal component analysis based the motion model for each patient. Under the PCA, the patient's motion is written as the linear superposition of the principal component, principal motion component, and we scale these coefficients to generate this realistic onboard patient's motion. In addition to that, we have a translational augmentation in the superior inferior direction to simulate onboard theta imaging error. By doing these augmentations, we can generate about 1,700-ish cases and divide into training, validation, and testing data sets. And we also compare our method with two other techniques for the real-time imaging. The first technique is the PCA-based 2D/3D deformable registration, which search for the optimal coefficients of the principal motion components. The second technique is the diaphragm tracking, which uses a diaphragm as the surrogate for the liver tumor. Here, I show you the results of the liver surface mesh overlap on the left and vortex projection on the right. So let's focus on the mesh overlap first. The upper left figure is the mesh overlap between the prior and the target mesh. The red mesh is the prior mesh and the yellow mesh is a target mesh. So basically, these figures show you the how is the surface motion when patient due to the respiratory motion. Most of the liver surface motion you can see is upper liver surface, and this in a different view. But also there are some small deformation at the lower side of liver boundary. The second row is the mesh overlap between the network deformed mesh and target mesh. The green mesh is a deformed mesh predicted by the deep learning network. So you can see there's a very good agreement between the predict liver mesh and the target mesh. You probably hard to see the difference from this figure. The third column is the vortex projection to the onboard X-ray imaging. So you can see the onboard imaging change due to the respiratory motion. The red dots are the projection from the prior mesh, and the green dots are the projection from the deformed liver surface mesh. You can see the deep learning network can predict accurate deformed mesh, especially if you follow the diaphragm region. So now we can obtain very good registration for the liver surface that can use to locate the liver tumors, like this. The lash overlay here shows, and here also shows the X-ray projection at another 45 angle and 80 angle degree projection. Here I will show you the quantitative results for the liver registration accuracy in terms of the Hansdorff distance for the 10 patients in latest data set, and I also compare with the PCA-based techniques. The first box is the Hansdorff distance between the prior and the target, so it reflects the degree of the motion. And the next three boxes are the PCA results at 0, 45, and 90 degree. The last three boxes are our results at these angles. This table summarizes the mean and the standard deviations of these two techniques. So you can clearly see our method outperformed the PCA-based method. We have a very good registration accuracy for the liver surface. Then we can combine with the biological modeling and use to obtain the intra-liver deformation to locate liver tumor. Here I show you the mesh overlap of the liver tumor for the 4 patients in this data set. You can see that the predict liver surface mesh match well with the target mesh for all the shape and sizes of the liver. Here I show you the liver tumor registration accuracy in terms of the dissimilarity coefficients, center mass errors, and hot-stop distance for these 10 patients. And this table summarizes the mean and standard deviation of these two methods. And also here I give you the results of the center mass error of the diaphragm tracking at the 3 projection angles. Here, the diaphragm tracking will only track the diaphragm motion in the superior inferior direction. So you can probably hard to see all these detailed results, but the baseline, the result is that our method has very stable performance. The registration accuracy doesn't really sensitive to the projection angles, and our central mass error is less than 1.2 millimeter compared to other methods. You can see the performance is worse than ours, especially for the diaphragm tracking. You can see the performance depends on the projection angle. We have a worse performance for the 90-degree because the 90-degree projection is in lateral direction. The diaphragm is more difficult to delineate from the 90-degree projection. That causes the worst performance for diaphragm tracking techniques. To summarize, I'll show you our proposed results to estimate liver and liver tumors from a single onboard X-ray projection. Our method is 2 steps registration-based skin. In the first step, we first estimate the liver surface deformation, use a deep learning model. Then we combine with the biological modeling, track liver tumors. And our result have shown that at the accurate surface registration, which will translate into the accurate tumor localization after the biological model. So before conclude my talk, I want to mention there's one speed bottleneck in the proposed method, which is the biological modeling part. In the proposed in biological modeling, we just use the conventional finite element solver, which is very time consuming. So we have replaced this by a deep learning based biological modeling using the UNet structure to predict the intraliver DBF. And we have some preliminary results. Now we can achieve the overall interference time is less than 100 milliseconds, which meets the criteria of real-time imaging. And I also want to thank the funding support from the National Institute of Health and also the UT Southwestern. Finally, thanks for your attention.
Thank you. The paper is now open for questions.
Yeah, it's a really nice paper. So during the treatment, does the mechanical, you have 140 CT at the beginning for the planning and for training, for fitting the mechanical model. Is that correct?
Correct. Yes, correct.
But what happens if during the treatment, say there's ablation or if there's change in the mechanical properties of the liver, your tumor versus the outer mesh may not the tumor may move within the liver differently from when you planned. Is that a problem?
That can be a problem. However, if we can anticipate that there's some causes that may cause the bottom modeling, we model doing the using the 40 CTs, then we can generate a new biological model. So it depends on how much information we can obtain to replace this biological model, because
you mean the tumor boundary model or the liver? Because I'm more concerned about the tumor boundary model and how the tumor moves within the liver, depending on the material properties of the liver. So presumably you're fitting a finite element model based on how the tumor moves in the 40 CT, but that may change during treatment.
The biological modeling part, we model the liver using some hyperelastic model. So we can use some hyperelastic model to model the liver. Typically that give a good accuracy.
Okay, thanks.
So we didn't generate the bottom model based on the 40 CT. It's a material model.
I see. Okay, thanks.
Hi, thanks for a really interesting talk. I was wondering if you would clarify your training, validation, and testing scheme. And so I think in your original diagram, you said that you were training on like the first 5 phases. Oh, sorry, 2, 3, 4, 5, and then validation and testing on the remaining phases. And so I'm wondering how that works because the phases are not like independent, is my understanding. And so if you're training on like the first set of phases of the motion, then it should be really easy for the model to just memorize the anatomy and then learn basically the perfect information for the validation and testing phases, because that model, at least with like respiratory motion alone, should be like very periodic. And so I'm wondering if you could clarify like how you avoid any sort of data leak, or if you tested for potential data leakage and overfitting between the validation and testing sets compared to your training set.
Okay, thanks for the question. We divide into this according to the phases of this 40 CT before this augmentation. The prior is the end of exhale phase. So typically the phase 6 is corresponding to phase 7 or between length is correspond to the end of exhale phase. So we train our model using the first 4 phases. Then, like you said, however, we pick, you can see we picked the phase 6 in the testing data set because it's quite unique. It's end of inhale phase. So typically phase 6 is not, you cannot really see other similar cases in the training or validation data sets. That's what how we test this. And phase 10, typically it was similar to the prior, but we don't have any prior doing in the training or validation data sets. So that's the idea to divide the training, validation, and testing according to the phase.
I see, thank you. So basically, each of the individual cases is predicting like a single static deformation vector field and compared to a single like phase of the motion and not a time varying deformation vector field. Is that correct?
Can you say again?
Oh,
Okay.
so basically like for each of these cases, you're predicting like the registration between like phase 2 and like the end expiratory or inspiratory phase?
It's we predict between the prior. The prior is the phase 1.
Okay.
Within prior and the other phases. For example, if the onboard imaging generates maybe from the phase 2. So the model predict a deformation from the prior to phase 2. However, to avoid data leak, we put phase 6 in the training data set because there's no similar motion like the phase 6 in the training or validation. The phase is the end of inhale phase. So it's the extreme cases that can avoid this data leak.
I see, got it, thank you.
Thank you.
Thank you. Well, let's thanks the speaker again.